So I'm pleased to introduce our sabbatical speaker today, Dr. Rachel Castaneda. She's a professor in the Department of Psychology in the School of Behavioral and Applied Sciences. She's a research psychologist who came to APU in 2011, and I actually remember that very well because I was in the dean's office, and he was coming in when psychology was under the College of Liberal Arts and Sciences. Prior to her taking on the Cougar stripes, she was actually a pure Bruin. She earned her master's,
all three degrees.
Her bachelor's, then her master's and doctorate degrees at UCLA. The bachelor's was in psychology, the master and Ph.D. degrees were in community health sciences and public health, respectively. He keeps my office, the Office of Research and Grants, pretty busy. In the past 2 academic years alone, Dr. Castaneda has received notice of awards for 9 external grants. I think it's 10 now, I should update this, that totaling close to $3 million. And included in that total is an award of almost $1 million for Project Wellness aimed at substance misuse and HIV risk behaviors with ethnic and racial minority youth, which was funded by SAMHSA, which is the U.S. Substance Abuse and Mental Health Services Administration. She is, as you can imagine, a prolific practitioner and scholar. Her APU CV is 21 pages long. That's at least the one listed on the APU website, and it includes 6 book chapters, 46 peer review articles, and 72 training workshops and lectures. But I think that's all those numbers are undercounted because the online CV seems to stop right around the beginning of 2019. So we're looking forward to some updates there. And today, she's going to take us on an international journey as she presents developing quality standards for substance use disorder, specialty care at the National Rehabilitative Center in Abu Dhabi, United Arab Emirates. Dr. Rachel Castaneda, you have until 1 o'clock.
Great. Thank you, Dr. Isaac. Thanks, Don. So it's a real privilege, a real treat, just to get highlighted like that. Thank you. It's been a journey at APU, particularly within the grants world. And so there has been tremendous support from my chair, Dr. Eklund's on here, from you guys at the Office of Research and Grants. And I look forward to just continuing and Mary Rawlings, have work partnered with her, and Ababois, we have potentially some research. So thank you all for just the partnerships and the support. And so I thought today I would spend some time on a funner project. And so when I took sabbatical, a funner project that entails and requires travel and hanging out with some of my best buds, which are like long-term colleagues. That's the best way to travel, right? But to do research and scholarship along the way. So I picked a program or project that I've been working on for several years, but it took shape within the sabbatical time that required travel. So I thought I would highlight some of that, but also what happened during my sabbatical was I got that 5-year SAMHSA grant that Don mentioned. And so that kind of shifted gears too, in terms of what I was going to be focusing in on for my research and sabbatical. And so, as you might imagine, I've made some adaptations and some changes, but so I wanted to, with all of that, I wanted to hone in on something that was pretty stable and solid and some fun that I've had that's brought some enjoyment to me. All the work has, although this one in particular. Okay, so the United Nations has funded several endeavors related to what they call TreatNet, and it's an international network of drug dependence treatment rehabilitation projects that I've been part of for probably 15 years. while at my time at UCLA, and I continue to hold an appointment at UCLA, Integrated Substance Abuse Programs. And so I've been able to still be part of this work. And what the work is building the international workforce in terms of standards around treatment. A lot of it is around standards of treatment, best practice models that they can adopt in terms of what we've learned from the science here to work. And then we translate it into the various international settings. And that's treatment. I just wanted to kind of give you a background there. But for this work that I did during my sabbatical time that I took last fall was, or fall, spring of last year, was really bridged out of a NIDA cooperative. So NIDA is the National Institute of Drug Abuse, and we got invited by a dear friend that we've worked with for a long time at UCLA. His name, he's there, we call him Dr. Jag Kasla. He's the chief, he's retired, but he's been back of NIDA's International Medical Consequences branch. And he's funded a lot of these initiatives, collaboratives with what I just TreatNet, and then a recent partnership with the World Health Organization that we've been working with largely around a lot of different international groups, but one in particular I'll focus in on like Don said, was the UAE. But I'm going to just kind of go broad a little bit. So within the NIDA context, the National Institute of Drug Abuse. So what's happening in terms of the context, what triggered this project and this work during my sabbatical was there's a big movement towards shifting away from just looking at treatment models and developing treatment models that work, but looking at how systems are performing. It's called performance measurement. It's called performance management. It's in the area of healthcare in terms of identifying national indicators around how systems are performing, like in hospitals. There's metrics around quality care. And in the area of substance use, we don't have those metrics. And so NIDA is really interested in developing them locally, domestically, as well as internationally, right? There's a movement. There's been a movement domestically. I've been part of a group with UCLA and various states for probably 10 years in the area of performance measurement. I have couple of grants through UCLA, continued with the state around performance standards and outcome measurement, but we've branched into international work. And because this shift of addiction being more embraced as a behavioral health issue than like a criminal justice issue or a moral issue. And so we've integrated it into healthcare context. And so now NIDA is like, well, let's kind of adopt some standards around performance for systems. And so there's been a lot of effort around this whole movement around system accountability. In other words, how are treatment systems performing? So we took shape, just some context there. Globally, there are about 255 million individuals who use substances, who report use in epidemiological surveys. And in terms of meeting criteria for having a substance use disorder, I call it SUD, about 25 million globally. And then the other issue is that millions and millions of people die each year because of addiction. And so there's within the population 15 to 64. And so it's a huge domestic issue as well as global issue. And so that pushes us to be like, well, what's happening in the systems? They have to be accountable. Like let's dig into these systems. And so I got invited, I'm making a face, I do this face. I'm speaking to around this notion, this area around the National Quality Forum on the left-hand side is this movement if we are gonna view substance use as a behavioral health disease, not just this substance abuse thing outside of healthcare, then we have to really embrace standards. And what are they? And so I was presenting to a forum internationally, invited by the World Health Organization during my sabbatical time. And really they have to do with things like access, the extent to which people that want treatment can get it as soon as possible. There's a lot of like, do they know what it is? Do they know where it's at? Is there a waiting list? Is there availability? Is there room? How much is it? Is it affordable? These kinds of things. So access. Then there's this measure of do they engage? There's initiation and engagement, which are really called early drop. Are they going to stay in? And so there's a real a performance standard is the extent to which they stay in services 30 days, but really we've benchmarked the first 2 weeks, and that's real telling in terms of, do they like the place? Are they engaged? Did they get services that they needed? So we call it early drop. Retention is how long they're staying in services. And if you think about somebody with diabetes or hypertension who have chronic issues, they can go to the doctor at anytime they want, because it's a continuous, they're retained in services. They have a primary doctor. This is an issue with addiction services because they've been set up to be these short-lived, community-based, isolated things that exist in a community. So this notion of retention is problematic because they don't have continuity of care. So there's a big problem there that's been identified nationally and internationally. So just bear with me in terms of how we measure retention. Family involvement, big thing. Mental health, there's a lot of family engagement, there's family therapists, but in the area of addiction, families stay outside of the addiction realm. They just drop people off or say, you go get fixed. So family involvement is really problematic in terms of it as an indicator. The use of evidence-based practices, the use of scientifically driven therapeutic techniques that include psychosocial, based counseling, if you will, that follow evidence-based techniques that have been shown to work to help people change and improve their conditions. In mental health, we know this is very strong, but in substance use, this has been very weak because of the workforce, right? We have registered and certified drug counselors that really don't get the same training that social workers or psychologists or MFTs get. And so this use of evidence-based practices of cognitive behavioral therapies, family therapies, the use of medications has been also fallen through the cracks within the addiction world. So how is that being done? How is that being pushed? So there's a big workforce issue. Treating psychiatric comorbidity. Substance use does not happen alone or in isolation. When somebody has addiction or a substance use disorder, they commonly have a co-occurring mental health comorbidity like depression, anxiety, trauma that is also problematic because it usually doesn't get evaluated when they come into addiction services, meaning they don't get a psychiatric assessment. They just get a substance use kind of intake at admission. And so that gets kind of left out. And so that gets untreated. That's a big system issue in terms of accountability when we're thinking about standards of performance. Also medical issues. Medical issues that commonly co-occur with addiction are things like HIV and hepatitis, and because of known occurrences of injection drug users, right? And so there's these nuances that really come to play when you think about behavioral health issues and are they being appropriately addressed in these treatment programs for addiction, or do they just kind of get ignored? And the National Institute of Drug Abuse, NIDA, and the World Health Organization are trying, there's movement towards really poking in on these, not just like ignoring them as we have for the last decades, but really trying to get some progress made with identifying some metrics and some issues to kind of carve out. And so, and then some other ones are patient satisfaction. Like, do we care what patients think about services? We do in healthcare. We do when you go to the dentist. You get that text like, "Oh, how'd you like your services?" You know, we get treated like, well, we should be able to report back how we like our services so you can improve them. In the area of addiction, that's not really done. It's like you kind of get something, you get a treatment plan, you get discharged, and it's like, yeah, we don't really care what you feel about us, how you feel about it. Unfortunately, right? And because a lot more times than not, that's connected to the legal system and they have to get a ticket punched, right? They have to come in and do their time. And so it's not really like you're coming into a healthcare service and we want to know how you received it. We want to know how you feel. So really this shift as well, right? Around the area of performance and quality standards. And then treatment effectiveness. I leave this to the last one because we really get dinged on this one as a field of addiction because we really have high rates of relapse. That means after they receive treatment, they use again and they continue to use again, which is meaning relapse, or they get readmitted into the justice system, or they get readmitted into an emergency room because of an overdose or some issues, or they get readmitted into treatment. We call it the recycling in of individuals with substance use issues. They're costly to the system, they're burdensome to the system. But then that's why NIH is like, well, are we doing our job? Are we treating them accurately and effectively? Accurately, that's more of an academic term, but are we treating them efficiently and effectively? And so I leave that one to the end, because if we do some of these other things right, then therefore this one should be able to then align more appropriately. So say that because we do poorly here. Relapse is pretty high. But what can it look like once we shift some models? So we spent some time looking at that, and I had the job of like educating or kind of highlighting national quality forum work in the US and how internationally it can be kind of shaped and spun into their arena. We got invited, there were several countries, of the 195 countries at this conference during my sabbatical that was sponsored by the World Health Organization and in the Eastern Mediterranean area, and NIH, National Institute of Drug Abuse. I went out with a team of my UCLA colleagues to really help. Of the 195 countries, there must have been probably like, I don't know, close to 100 or so represented, all in the area of addiction and behavioral health, right? Shifting these models. And really you see there, it's really strengthening this framework or a public health, shifting it into the public health arena to substance use. And as Don mentioned, this is one of my areas of training in terms of community health sciences and public health. And so this is a long-term time coming. So it's one of why I really like this project, is really it's taking addiction and it's bringing it back, integrating it back into public health systems where it belongs. So we were invited to really kind of hone in on, if you look at governance, and then the second area there is monitoring and surveillance. One big thing that these countries, most of the countries don't have that the US has, when you want to measure, have a quality system and accountability, you have to have data, right? And a lot of these countries don't have data systems that are robust. In the US, we have epidemiological monitoring systems that counts prevalence of incidents of admissions or those that are using alcohol and drugs. We have a pretty robust surveillance system of identifying substance use and need for treatment. We work with emergency room data, we work with justice data, we work with social welfare data, coronary poison control data, treatment admission, right? And there's national surveys to look at consumption. When you look at the 100 countries that were there, the 195, they don't have these monitoring systems. So how can they, so that's a big kind of gap. So we started there. This was my group that I was in charge of during these breakouts. And I trained them and kind of talked about the national quality model around, if you are going to develop performance standards, you need data, but you then also need to look at, in order to know like what they're doing in your system. And so there's 3 areas we've kind of honed in on. It's prioritization. You need measures that you're going to select that should be meaningful and relevant to your services you provide. And that's why I'm going to we'll go through, like we looked just at the National Rehabilitative Center and their electronic health record, their data, because there's not a one-size-fits-all model with all these countries. You have to kind of look at what is meaningful, and then they have to prioritize based on what's the drug of choice in their country, what is the kind of ongoing areas related to law enforcement and legalization and these kinds of things. Operationalization, we have to define and put parameters around these metrics, and it should be clear. They should be able to measure it. They should be able to, their system should be able to report that back out. And then it should be feasible, low-hanging fruit. They should be something that they can kind of build in and not be very difficult, but they should also be feasible in terms of have an empirical framework. They should go into it, like they should understand validation and processes. So that's why they're looking at what's like benchmarks. They want to be able to compare against, well, in the US or in this other country, they're performing this way using this standardized tool that monitors X, Y, and Z. Like we have National Survey on Drug Use and Health. We have the Monitor in the Future. We have all of these robust kind of epidemiological systems that have validated streams. They lack that, right? And so raising their attention to that. We then also, I was part of a panel in UAE as part of this collaborative that then would then discuss performance metric systems for this specific region. This is Dr. Tarek. He oversees the National Rehabilitative Center, and on my right, that's Dr. Rawson, although it says Rachel Gonzalez in front of him. He hired me when at UCLA, gosh, when I was 18, right? So I've worked with him for a long time. He's a clinical psychologist researcher and gets a lot of work, works with NIH for several years. So we've done this collaborative partnership for quite some time. And so this is the NRC when you enter into the National Rehabilitation Center. And we visited this place during the sabbatical to then meet with the team. And so when you are going to do performance measurement, you want to like have clinical folks, you want to have their data folks, their IT, you want to have the P people, we call them the P guys, or those that do drug testing. You want to have a lot of folks involved to be able to speak around these areas that I just covered, like prioritization, operationalization, and feasibility, right? And so we're now going to hone in on that protocol here at the NRC. So the UAE, UAE stands for United Emirates, right? United Emirates. And then so it's in Abu Dhabi. There we go. Emirates.
United Arab Emirates.
Emirates, thank you. I just say the UAE. Although I used to just say I'm going to Dubai, but I didn't go. I flew into Dubai to then travel into Abu Dhabi, by the way. That's how much I don't pay attention to detail. But services started at the UAE in the early 90s in terms of addiction services, but they were through beds that they were in these existing psychiatric hospitals. So on the chart here, they had the Pavlovian behavioral site. It was a psychiatric hospital. And then they have the El Amal hospital. They really didn't do addiction. They did psychiatric stuff, but not really addiction. And that's what's the thing at several of the countries. And that's part of the issue, is really shifting to incorporate substance use, because you might imagine substance use is illegal. And so they're just, cut off and thrown into their justice system. And so it's really reopening them back up into how do we integrate substance use into psychiatric settings, is that's what is happening in a lot of the countries to establish the system. In 2002, so the NRC offers detox. On the right-hand side, I bolded it. Detoxification, which is not treatment. It's just like a place where individuals come in, particularly to detox from alcohol or opioids out of their system, and they have to be medically monitored. And so that's usually runs for the first 2 weeks of service. And then they can be put into rehab, which is inpatient, outpatient types of settings. And like I said before, it was established or inaugurated not because of data, because there really is no epidemiological data to say, well, what is the problem with drug addiction in the NRC or in these countries? Because they don't monitor it. They just, if they catch it, they get arrested, right? And so that's part of the problem. But it was this presidential decree that they need to establish a substance use kind of addiction or a rehabilitation center that was different from psychiatry. So just giving you some history there. How does this differ from the US? This is a national snapshot of, we call them specialty substance use disorder treatment programs, if you will, around the country. We also don't do a great job of integrating them into healthcare or mental health. It's real turfy. Mental health stays kind of separate. There are some more shift around. We're having a lot more shift around that into integrating it into practice in various settings, but it's largely isolated here too. into these what we call specialty treatment centers, if you will. And so we have on the left-hand side levels of care, but in the country there's about 11,000. Most of them are outpatient, where they go into from to receive services. Intensive, it's just severe frequency of services difference between intensive and outpatient. Like outpatient is 3 times a week, 3 days a week for 90 minutes, and intensive would be like all day for 5 days a week. Detox, there's pharmacotherapy programs like methadone, but we're shifting beyond just methadone programs to offer new medications that are available for addiction, like buprenorphine and Vivitrol, which is like a naltrexone. And then residential inpatient settings, and then non-hospital, and then hospital-based ones like a Kaiser. There's not many hospital-based ones, as you see there in the numbers. So this is just as comparative to like what this, like a smaller country would have. They only have 78 beds compared to like we have a lot going on in our country. This is, we went during the flag ceremonies and Flag Day, where they celebrate the development of their country. And so I just found that was interesting. That's the front of the National Rehabilitation Center. And so just wanted to give you a sense. And that's how many of these in their white suits, their garb, a lot of them are counselors. And then guys or girls, right? And they have, they just wear that day, and it's like what they wear in terms of Arab. But if there's Egyptians we work with that don't put the full on garb. So you'll see some with and without. There's a lot of cultural stuff I can kind of integrate, but in terms of time. So we, just to give you a background, the pilot evaluation we did is we looked at their data, their electronic health record there, and we snapshotted it between the year prior of January to August of a year of total admissions or a readmission that had an admission and a discharge within that period. So it was about 720 patients. They do see a lot of patients. This is access, one of the performance measures that we were kind of wrapping our heads around. And about half of them are going into outpatient. Several of them are going into detox, and then they'll transfer into an inpatient program, which is the involuntary or voluntary. These are residential. They separate females. Most of their patients are male. They don't have a lot of, they call them juvenile, but they're adolescent client patients, if you will. So that's here's a demographics of the 720. Most of them are male. Left-hand chart. Age groups 21 to 30 make about half, a little over half of them, and then 31 to 40 about a quarter. On the right-hand side, over half, about 60% are single. A third are married. And then education on the bottom, most of them have secondary level of education. And then employment, most are not employed that are coming into the treatment realm. Abu Dhabi, the UAE makes up a big area. And so where they're coming from in terms of the city location, many come from Abu Dhabi, but then some come from the outskirts of Dubai, Al Ain, and then Sharjah. And then some of the, in the middle of these bubbles are on the left-hand side, some of the other cities or locations in the area that they're coming from. And they have to travel fairly far. And this makes it difficult when you want to measure things like retention, right? And like from an outpatient setting, like to and from. So access is a big deal. And so we ran into this problem and we gave them feedback around this. And they really need to grow and integrate this into like hospitals and other settings that are more accessible. So looking at dropout rate, they actually have pretty good rates. When you look at, on the right-hand side, this is the US, right? And so on the right-hand side, this is a systematic review or meta-analysis of psychosocial substance abuse treatment and the rate of dropout in the first 2 weeks, like I told you. And it's about 30% of those US programs that I showed you. If you look at the left-hand side, they have about an 8% dropout rate. I mean, they have a smaller number, but people stay in treatment, and mainly because most of them are there involuntary, right? So, and we have that, we have this issue in the state, in our country as well, in terms of the justice involvement where they're mandated to treatment, right? And so that's not too different from this context. So there is something there where they're staying there and kind of maybe like kind of unpacking the cultural dynamics of the US versus international, and the shame and stigma around substance use in general. And so we've talked about that with them in terms of indicators and thinking about context when you're developing performance measures. What are they using? A lot of them are using amphetamines, the pink bar, stimulants, and then a large number are heroin, opioid users, and then alcohol, other opioids, and then a lot of sort of other things that you can see there. Tramadol. Some of them are opioids, but they wanted them to be broken out for them in terms of what they're using. But stimulants and opioids, cannabis, and I'll say this in a little bit, is a growing concern, but not just cannabis alone. High THC concentrate cannabis that's being interacted with fentanyl, with opioids. And so this is becoming more and more of a concern for them. So when you look at a national indicator or a national performance metric, of which is the use of evidence-based practices, you're gonna wanna make sure they're addressing the type of drug, like amphetamines or opioids or alcohol, with the known evidence-based practice. And so, for example, they use a lot of practices, by the way. Here in the country, in our states, it's like, what do you do? And they're like, we do relapse prevention, right? When in terms of, you look at the treatment programs, when you ask them like their use of services, you see that on the bottom, they just use a lot of stuff, like social skills and time management and anger and a psychology group and a group therapy and an impulsive control group. And it's like they do a lot, and they just kind of pull from their kind of tool belt stuff that they want to use. They don't have any standards or protocols around it. And that's really different from the US, because we use evidence-based practices, like think about our federal SAMHSA hub, Substance Abuse Mental Health Service Administration, where we have manualized protocols of like, here is a 12-week kind of regimen. And there's some flexibility with psychotherapy and being able to have autonomy and build some stuff in. But when it comes to building in some of the evidence-based structure of the manualized approaches, they don't have that. They have one, and it's called Matrix. I highlight it there in the 579 in the middle. And Matrix is a combination there, I showed there, of cognitive behavioral therapy and contingency management. This has been identified as an evidence-based practice for stimulant use disorders in particular. And so they have been trained through that TreatNet, like I started off earlier, to adopt Matrix. So Matrix has been pushed to a lot of countries. It's a 16-week model. It's an evidence-based gold standard, particularly if you have methamphetamine or cocaine. So they are using Matrix and with Fidelity. We've done some studies there. They do step group. That's something that's common in our country in terms of the 12 steps. They do offer that in terms of support groups. They call it just the step group, which has also been shown to be a very robust service for addiction and just this whole notion of social support, particularly since you'll see in a minute, family don't get involved even internationally. So it is a community of support system. There's a large degree of reflection, and we asked what this was, and they said that it's a processing group. So this is something that just they open-endedly, they do a lot of individual one-on-ones, and they call it just reflection and giving them time to do one-on-one and individualized services. So this is something interesting and different than we do in the States, where in our models, we don't do individual therapy. In our models, we do group. That's what they get. If you look at I just showed you that US snapshot of programs, the majority of programs in the United States are group-based treatment for addiction. And so they do it very differently. They don't do a lot of groups. They do individual, but they call it reflection. And then they do mediation. And so mediation is another thing, and it's between the justice we would call it here case management, right? And so it's interesting, they call things that are differently, but they do a lot of interaction with the government, so to not get them like killed or kind of cut off or imprisoned forever. And so it's interesting and it's different than what we do here. In terms of medications, one of the national quality standards that has been pushed in the US, it's interesting. I just got a SAMHSA grant, a training grant with the nursing program here at APU to use medications, to train nurse practitioners on the use of medications for addiction. It's a big area in our country around pushing the use and adoption of medications for opioids. I highlight them there, naltrexone and buprenorphine, because they really have been, they're FDA approved to help with things like craving and withdrawal issues that have largely been left out of the addiction treatment settings. And so this, but not in this country, they have adopted medication and embraced them, quite frankly, a lot faster than we have in the country. There's still a lot of, in our country, shame and stigma around the use of medications in treatment programs. And a lot of it for us has to do with workforce development. I started off saying that we have registered and licensed counselors called substance use counselors. And so here in Abu Dhabi, they have psychiatrists. They're trained clinicians. They have psychologists and trained social workers. There's no such thing as a drug counselor or registered counselor, right? So there's a workforce issue. So they're able to use a lot more, again, individualized services that, they get trained on, psychotherapies and they're adopting a lot more of the medication. Acompressate is for alcohol. This is just the FDA approved ones. On the left-hand side, it's for alcohol. We have for FDA for alcohol use disorders. And then on the right-hand side, these are for opioid use disorders. And so methadone has been around for a long, long time, but we're trying to shift away from methadone because that's sort of lifelong. It's another opioid, and unlike naltrexone, buprenorphine, there's dosing, and then they want to titrate you off of them just to help during the initial kind of stages, 6 months of craving and withdrawal. They don't use methadone here in the country. So that's another thing. They didn't start with methadone. In our country, we started with methadone and now picking up some of these other ones. And so we can learn some lessons from others as well. Issues with family support. Families don't get involved. There's a lack of family involvement. They do attend support groups. As you see in the bottom, early recovery, relapse prevention, social support. But they don't really have the data. So when we asked, like, how are you measuring this? They just said, oh, if they've called, or oh, if they've attended, or oh, if they've shown up and dropped them off. And so this is a really mucky measure, by the way. And so there's a lot of issues with social support. Treatment effectiveness, this area of relapse, they actually have went up from previous years. They were below 50% and now they're above 50%, looking at the data. And part of the issue is, they're lower than the US. Relapse rates in the US go up to about 90%, range from 80 to 90%. Lowest is 65 in terms of our relapse rates for those that have participated in treatment. So what relapse treatment effectiveness means here is that of those who have completed like an outpatient length of stay, if they will, admission, discharge, and then 3 months later, they look at, have they used drugs again, or 6 months later. This is a 3-month rate. This is a 3-month window. You want to see if they've used the drug again. This is what relapse would entail. And so it's pretty problematic in the international context as well. And so there's a lot of issues with what's going on. And so we've kind of given them some hints in terms of what's going on in the US. So it's the co-occurring use of other drugs. And so when they come into their treatment programs, for example, with all of these, they call them primary substance use disorders. The thing of it is usually somebody with substance use is using multiple substances. And so if they're gonna come in for, like, let's say heroin treatment, they're also probably using cannabis and drinking, and that doesn't get addressed. Or if they're coming in for a stimulant substance use disorder, they might be using some of the other substances, and that gets left off the table. So this has been problematic in terms of recovery and helping people achieve complete abstinence, if you will. So there's some growing concern, like I said, with cannabis. So I did a workshop and some training in Cairo during the sabbatical with their faculty of medicine, their psychiatrist, which is on the left-hand side. And I talked about cannabis, different types of dose, and the differences between plant-based and then these extracts and the waxes that have high concentrate of THC, like almost 80%. And that's what they're seeing there as well. And so that's something that their government and they want to kind of get a handle on, because for them, cannabis, just like in the US, has been like, well, is it really a drug? Is it really problematic? And then on the right-hand side, this is at the World Health Organization conference where we kind of highlighted that as well. The other thing that's happening with relapse, and I told you this before, is they don't, from a performance accountability standard, they don't necessarily treat psychiatric comorbidity, right? And we do we in the US also have issues with this because they're separated systems in mental health, substance use, and healthcare. And so this has been a big issue internationally as well for treating co-occurring disorders, the psychiatric and the medical, like HIV or hepatitis. So when we looked at their rates of co-occurring, they do have really high rates of drug-induced psychotic disorders that are going unaddressed. And this is linked to the amphetamines. And we see that in the US. And so this lingers, and this kind of can translate and manifest itself into like schizophrenic-like issues, continued neurological damage that then would trigger somebody to relapse and use again. And so we don't do a good job. We don't have medications for stimulant. We have medications for opioids. We have medications for alcohol. We don't have medications for amphetamines or stimulants yet, not even in this country. And so the best practice in our country has been to use psychotic, mood disorder related antipsychotic medications, but that shift is slow and it hasn't been translated internationally. And then you look at other rates of mood disorder. These, we don't know also if these are appropriately assessed in terms of psychiatric assessment, in terms of them spending time really doing a thorough psychiatric assessment. So that's problematic. And then the rate of infectious diseases, hepatitis B, HIV. This isn't based on actual like blood tests. This is based on self-report. Even though they call it bloodborne diseases, this is problematic in terms of their measurement and picking up the co-occurring medical issues. And then as I wrap up, some of this work we presented at this in a conference during COVID, this last March time at the CPDD conference sponsored by NIDA. And so we reported on performance measurement around the National Rehabilitation Center as the pilot, and really honed in on the measures we talked about: dropout, family involvement, and then the use of evidence-based practices, particularly that medication and issues with that. We wanted to hone in on access, but we couldn't really get to that in terms of how to benchmark it, how to prioritize it. And so we're still spending some time with them trying to expand upon it. And so if you see here in the middle, there's some definitions of measurement we came up with their team, but it's still being finessed. And that's part of the development process of performance measures according to the National Quality Forum. And so it's an ongoing process, a nuanced process. We submitted a paper right after the end of my sabbatical, we submitted it to the Journal of International Addiction around this whole performance endeavor. We partnered, Dr. Tarek Gawad is from Cairo and Abu Dhabi, and that's why we have partnership. We were in Cairo as well during this stay. here's a picture of some of the clinical staffs. Many of them are the psychiatrists. On the left-hand side, there's Dr. Rawson, my UCLA colleague, the only other like white person here. But on the left-hand side, these are all psychiatrists at the NRC. And on the right-hand side, well, there's one other gentleman on the back, Dr. Nail. He's a psychiatrist. And then there's his wife. And then the woman, Muad, with no garb, she's a psychiatrist. And then some wives, and then I'm there with them. And another thing with the work here is there's like, we do dinner like at 9 o'clock at night, but for us it's like breakfast time, and it's really tiring, and there's big meals, and it's part of their community engagement and planning, and it's a whole part. It's not like here what we do in the States where it's like, okay, see you tomorrow morning, and I'm gonna like go catch dinner in my room or something. It's this whole ordeal, and it's fun, but it's a lot of social, it's taxing on you socially. And so I'll end there. If there's any questions or comments, I know people had to drop off, but I hope it was informative. And the food looks good. And I know you've kind of spent your whole lunchtime with me.
I had a question just on your use of terms. On one of your early slides, you said there's 255, it was written on there, 255 million substance users worldwide.
Mm-hmm.
What do you mean by substance users?
So they report substance use based on surveys. So it could just be, they pick it up that way.
Okay, does that include prescriptions?
So you bring up a good question. So we have some complexities with measurement in terms of what that entails. And so it could be also in the past, is it in the past 30 days or is it ever in their lifetime? Okay. So there's a lot of complexities. You poke in on something that we just grapple with in terms of, we have pretty much our epidemiological system. When we want to look at the scope of substance use, we have to look at multiple indicators, like who's in treatment, how many people are in treatment, how many people have got arrested, how many people with involvement in substance use and they were tested, how many people are in the emergency room for an issue but the substance use was involved, how many deaths the coroner and substance use was involved. We can get a better glimpse. So that number, Don, is just, I mean, that's based on like survey reports, which have also issues of like the complexities of like, what does that include? And prescription versus, does it include tobacco? We get questions like that. And then does it include alcohol? Like is it illicit drugs or is alcohol? So there's a lot of complexities there. That's why I put it smaller on the corner.
Okay, yeah, because 255 million, it's almost like, I would almost guess that would be the correct number for the US.
Yeah, well, no, it is the US. It's not the countries.
Because I thought it said worldwide.
250, how much is the number? Let me see.
It said 255 million.
Oh yeah, that is worldwide. The US is more like 20 million.
Wow, that seems low.
In terms of use, yeah.
Okay. Okay, so that just highlights, like you say, a problem of metrics.
It's a problem of measurement and yeah. And the other thing is a problem of reporting. Like when they do there's issues with underreporting. Nobody wants to report that they're using alcohol and drugs. Right, so there's just measurement issues, unfortunately.
Okay.
Rachel?
Anybody else?
Hey, Martha.
Rachel? Hi. Good presentation. I had a question. In Cairo, is there any difference on how the users are treated based on age? Do they get more care, more services when they're younger than when they're older?
It's a good question. You know, my area is young people, like youth is what I typically focus on. And according to their anecdotal reports is that youth don't have problems with alcohol and drugs. It's only when they get older. And I was like, I just think they're not telling you. they're not getting in trouble, right? And so they don't have a surveillance system like we have Monitoring the Future. We have the CDC, the Centers for Disease Control, that does the YBRS, the Youth Behavioral Risk Survey, like every year, that looks at like risk indicators of just alcohol use, tobacco use, just like seatbelt use, and nutrition and diet and physical activity. Like we constantly capture that, but they don't have any high school based surveys on we're going to come around and ask you about alcohol and drug use. And so it's an interesting phenomenon. They do have some juveniles like in UAE, but like there's 4 of them. There's not many. Many of them though go into psychiatric hospitals or psychiatric systems. So they do have mental health, youth more robustly in mental health. But when I ask, well, can we look at the substance use? They say, well, we don't collect it because they don't use alcohol and drugs. It's interesting.
Yeah, that is.
Mm-hmm.
Hi, Rachel.
Hi, Jody.
Hey. Oh, like kind of on the same line. Like, is it any different between gender? Like men, because in the Middle East is male dominant society. So, is the treatment side, is it any different between men and women? You know.
Yeah. So in terms of there's a big growing concern around identifying women who use alcohol and drugs, and because the numbers again in this context are very low comparative to the US. And so many of them just say, well, anecdotally, they're just home taking care of the kids. They don't go out and use alcohol and drugs. So it's a cultural kind of artifact. But there are women that are in their system, this small number though.
Could it be just due to underreporting?
Yeah, so that's the kind of anecdotal we hear, that there's just a lot of underreporting, and there is higher use of prescription medications among the women that just aren't, like they're not using the meth and the alcohol and the heroin, but they're using prescriptions that are just kind of going under the radar. It's a good question. Yeah.
Let's see, last week, Oregon, the state of Oregon here, voted to decriminalize, first state that voted to decriminalize use of hard drugs like heroin and cocaine. Basically, to summarize it in a sentence or two, the law would make it so that if you're caught with a non-commercial amount of heroin, cocaine, and a bunch of other drugs, you're subject to a $100 fine, which will be waived if you go and seek treatment. In your professional expertise, is that a step forward, helpful? What do you think?
So I don't think I think there's a big movement towards the decriminalization of alcohol and drugs, a shifting away from them being like felonies that then affect their like sentencing time, right? If they're caught with possession of a certain amount, then prior some of the laws were you get up to 5 years and it's a felony, and then that affects your ability to get a job or like get loans for school, right? So there's some quality of life kind of impact there. So there's been a lot of effort around decriminalization.
Right.
But in terms of complete legalization and then giving them the abilities to go to treatment, when you do have alcohol and drug and you have a disorder and your brain is in a diseased state, they are not in any way, shape, or form interested in treatment, right? So there's an interesting nuance with addiction where the justice of having them go through maybe a drug court and go to treatment and still have them engage within a treatment realm of healthcare should be a priority. When you completely leave it up to the individual, we're not going to see that probably be executed or implemented as one might imagine. Just like somebody with like a psychiatric, when they said, well, let them opt into treatment psychiatrically, it's like, who's going to go to treatment psychiatric when they aren't in the right state of mind to make those sort of decisions when their brain is in a changed state.
So,
And so
well, so if they opt to go to save $100 fine, you're suggesting it's not serious.
It's not serious.
Okay, interesting.
Yeah. No, I don't. I mean, I do think that there is a lot around social equity right now, and the whole war on drugs movement and the war on people that's going on. And I think it's integrated into this whole area of policy reform. But I really do think that there needs to be shift around how healthcare and mental health services get integrated back, get expanded to incorporate substance use, and not just right to just go to this treatment program, because that's the real problem, because they're not addressing some of the underlying areas of need.
Okay.
So we have a really broken system.
Okay. Well, our time is
I have a
up.
question.
Okay, we
I
got
have-
the last question from Abu.
I actually have class at 1, so I got to jump off. But Abuba, yeah, I can take it.
Thank you for this excellent presentation. What do you think will be the long-term strategies in terms of this high relapse rate, both in the US and also in Abu Dhabi?
What I just mentioned, I think the integration into healthcare and the mental
Healthcare.
health. I think that the lingering areas that don't get treated are the mental health disorders that they leave substance use treatment. And the thinking there was like, you treat the addiction, but and the mental health problem will go away. And that's not the case. And so I think the long-term strategy should be more of integrating it into more long-term, the way we deal with general healthcare. When you have some issues and you need assistance, you can be able to walk into a doctor's office and say, I'm having some trouble, and having an ongoing therapist or social worker. But that's not the way, from a cost model, our services are designed. Medically, we have that ability, but from a mental health and behavioral health kind of standpoint, we don't have that. We have the model of, like, you use drugs, okay, well, go get something for 3 months and you should be clean. You should be like free from addiction. And that's just not the way our behavior, it works. So we need more chronic, long-term continuity of care service models that really address the underlying issue of why they're using alcohol and drugs, which is the mental health conditions, more so than not. So.
Okay, well, we'll have to let you go now, Rachel. Thanks so much for squeezing us in here. That was really a great presentation, and we hope to make it available to a lot of other people.
Thank you. Do you want me to send you the slides?
Well, I think they got recorded.
Okay, cool.
Yeah, the whole thing got recorded, so we're good to go.
Everyone.
All right.
Bye.